little bit more about myself. My name is Min. I'm a dental technician based out of Windsor, Ontario, Canada. I've been in the industry since 2006. So this year actually marks 2 decades for me. And I spent the majority of that time just like this, behind a computer, using a mouse and keyboard. One of the first users of 3Shape globally, actually. I've been a KOL and beta tester for them for a number of years. I helped run a study group as well. But in that time, I've used all the ranges of technologies when it comes to digital dentistry. So milling, 3D printing, any kind of software that you can think of. I've probably had my hands on it at one point or the other. So just very happy to share with you guys this topic today. And of course, the topic again is managing implant challenges in the aesthetic zone. So we're going to start off today by kind of defining some of the background and challenges that we face when working in the aesthetic zone, and then the products that Elos has that kind of help to address some of these issues. So of course, the aesthetic zone, when we talk about it, is the anterior teeth, the ones that we see when we speak or smile, and the surrounding soft tissues as well. And these are what patients really are concerned about when they go and they're looking for cosmetic dentistry. And these challenges are multiplied quite a bit more when we talk about it in the context of implant dentistry. So of course, patients, this is where the area of high visibility and patient scrutiny exists, right? So they're always looking when they get it delivered, they'll lift their lip up. They'll be very, very particular about how these restorations look. When we look at it again from that implant context, that bone volume that we have there, I'll show you guys a couple slides as well about how bone volume really does dictate implant placement. We speak a lot about prosthetic driven or restoratively driven implant planning, but ultimately we are limited in where we can place these implants because of the trajectory of where the bone exits, right? So regardless of planning, we are limited by that bone volume. And often these patients have compromised situations where, there's trauma, there's some kind of periodontal involvement. So there's usually less than adequate bone there. So we're always kind of doing some kind of compromise to get an implant in that place. And then that narrow restorative envelope that I'm speaking about is really, again, the aesthetic zone. These teeth are very thin, very tapered. It's very unforgiving if you have any material or excess bulk. I work at a lab I own a lab that has, we focus on more premium products. We offer, veneers, aesthetic implants. And the main focus is really, getting really good matches on single units and things like that to try and differentiate ourselves. And I learned a long time ago that you can get away with a lot of really good contour, even if the shade is a little bit off. If your contours are off, that's much less forgiving than if, your shade is bang on, but the crown is bulky, right? So that narrow restorative envelope gets really multiplied by the abutment material underneath that crown. So any kind of bulk or excess in that restorative envelope is very challenging to manage. And then finally, any small angular deviations. Nowadays, when we're placing implants, we have a lot of bone level implants. They're placing them deeper as well, just to try and get a nice emergence out of them. But the deeper you go, the more that an angle is off when they place it, that deviation is multiplied much further when you get towards the incisal edge. So in that aesthetic zone, again, if it's exiting out of the facial or in the incisal edge, very difficult to control. So again, that bone volume, when we talk about it, typically I do like to plan as many cases as possible. We are involved much earlier in the process as well, which is a wonderful thing. But you start to see this, right? So you can see what I'm speaking about is the sagittal alveolar inclination. So typically the bone in the anterior maxilla is always tipped backwards a little bit. You can see here this patient likely experienced some kind of trauma as well. There's also periodontal involvement where the actual CEJ, or where the bone meets, the crest of the bone meets the alveolus is quite low here, quite high. And so now when we look at the planning, we're probably gonna have to place an implant more palatal this way, as palatal as possible. Typically in an upright position would be ideal, but then of course the apex of that implant will not be able to be there because you may perforate through that cortical plate here. So we're gonna have to tip it backwards following almost this long axis of the existing tooth. Of course that exit causes some issues where that access channel will need to be exiting either through the facial or through the incisal edge. So of course we try and solve this in the past by doing cement, like a custom abutment with like a cement retained crown, but we'll speak a little bit more about cements and their effects on the implant health as well as soft tissue health a little bit later. But yes, this is one of the big challenges, especially in that aesthetic zone. So of course, here's some classifications of the actual types of bone and kind of the configurations you can see here. where, you know, A1 is kind of your ideal situation here. And it's very rare that you would have an ideal situation where you have healthy bone and a tooth in the right inclination. But this, if you have a case like this, you know, implant placement would be fairly straightforward. It would follow typically the long axis, or we'll upright it ever so slightly so it just kind of engages that lingual cortical plate. And then you're able to have an access channel that comes out slightly behind the incisal edge there. You also have adequate bone volume vertically and horizontally. In this A2 situation, there still is adequate bone volume, but maybe there's misalignment of the actual tooth itself. So in the case like this, where you're going to place an implant, there may be a little bit of a gap that we need to look at, you know, doing some kind of socket preservation, jump gap, or some kind of grafting to make sure we get that implant in there. But again, fairly easy, not many complications that we would need to worry about. It's just a less than ideal angulation. And then the B1 and B2 are the less than ideal. So this one here has slightly less bone volume. You can see there's, you know, some kind of periodontal involvement here as well. The inclination is still fairly ideal here, but that we would have to likely place an implant slightly deeper in this situation. And then the least ideal here is where, you know, you don't have inadequate bone volume and inadequate angulation. So at this point, you know, we need to look at how do we augment the ridge, how do we graft, as well as when they extract this tooth, for example, if they take it out, is this whole facial plate just going to disappear on you? So these are things that we kind of manage when we go into the planning aspect. But of course, again, we're dictated by where the trajectory of the bone is. So of course, you can see these examples here where we place an implant. This is very ideal here, where the proposed crown that we kind of plan here has that access hole exiting through that palatal region there. This trajectory here is still acceptable. We're trying to engage more bone. Typically, if you're trying to angulate the implant in such a way that you're engaging, you know, cortical bone, which is a little bit more dense, as well as trying to get it in a place where you're accounting for recession of the bone as things remodel. Again, this is exiting out, you know, in a slightly less than ideal position, but with the advent of angled screw channels, we are able to correct this. Same with this one here, exiting through the incisal edge. Again, not the most ideal situation, but not the end of the world, because we can always angle correct this. In a situation like this, it's less than ideal, obviously, because it's exiting through the facial aspect, but also we run into the problem of emergence, right? And we'll speak a little bit about that in the next few slides. But the emergence of this crown as well, now it makes it very difficult for the actual supporting material to have, exist in this area and then have a ceramic material on top. It makes the crown very bulky, right? So managing an implant like this is very, very difficult. And again, we're talking tenths of a millimeter, and a few degrees makes all the difference between any of these, right? And the deeper we go, again, it makes a difference as well. So implant placement, again, there's a bunch of consequences, and obviously we can't control this if we're not involved in that process. That's why I'm also a huge advocate of, you know, the implant planning and guided surgery. And if we can, though, we need to also keep in mind, you know, implant depth, implant angulation, how it is mesial distally, and how that all affects the emergence profile and, you know, ultimately the restoration that we are working on. So all of these are very, very important and critical when we're hopefully involved in the implant planning process. But once the chicken's been cooked, you know, then we're tasked with really trying to overcome any challenges in this aspect. So the last part of it, of course, is emergence profile. And the emergence profile, especially in the aesthetic zone, is absolutely critical because the last thing you want to see is, you know, a flat, blunted papilla, and it really gives things away. So this emergence profile is very important, and we've understood in the last number of years that, you know, having a more narrow emergence profile there's typically a lot of bone. Things are very kind of jam-packed in there. So having an emergence profile that emerges very naturally, so you can make a crown look like a natural shaped tooth that has a little bit of a taper to it. Having the abutment material emerge in such a way that it preserves that emergence profile. Very, very important, both from, you know, the periodontal peri-implant aspect as well as the aesthetic aspect. So of course I speak about screw retain restorations. Screw retain restorations are really the standard of care nowadays, in my opinion. We have both the technology to be able to produce many restorations, almost all of them in a screw retained manner, especially now that we have angulated screw channels, both in, you know, a stock part like a titanium base, as well as in custom fabricated patient-specific abutments. So screw-retained crowns, and the number one reason is we just want to eliminate the likelihood of cement being left over. Any kind of cement residue in that peri-implant zone can cause inflammation, it can cause peri-implantitis, and which ultimately leads to implant loss. So the ability to cement these things outside of the mouth and then deliver it. The other benefit, of course, is with that screw access channel, it makes things very easy to retrieve. So be able to take the crown out, if the patient's slightly symptomatic, they're able to take the crown out, put a healing abutment, let things settle down, reassess. Maybe, a contact is a little bit off or something like that. The ability to adjust makes it much, much easier. So, of course, that screw access channel does involve a couple of, number one, aesthetic as well as functional challenges as well. So, again, we have the advent of screw access channels in both our titanium bases and custom abutment restorations that we're able to produce now. But of course, there are some compromises. It's not 100% perfect, especially in the aesthetic region, right? So when you're working with a screw access channel and you have to tip it back, sometimes you are limited with how far you can tip that back based on the inclination of the implant. So that can result in ceramic thinning or a little bit of graying where that access channel exits. So you'll look at the crown, the mesial and distal lobes or the aspects of the crown look very solid and kind of opacious due to the material that you're using, but that thin screw access channel does result in potential graying, right? They will they'll block it out with some kind of composite material when they actually fill that access channel, but there is a chance for shade inconsistency in that area there. So there is that optical compromise that we're always worried about. Also, if you have occlusion right in this area where it's exiting, because of the shape of it, you can have increased fracture risk in that area, a little bit of chipping around the screw access channel as well. So just some things to consider, even in the posterior region, this can happen, right? So if you have it right in the central fossa and it's just in a heavy contact area, something to really consider. We do try to design crowns, obviously, slightly under occlusion, especially implant crowns, but there's always that likelihood that the tooth opposing is going to erupt and cause some chipping. So be very strategic about where you place the screw access channel. If you can get it slightly further away, that's always good as well. So of course, the ASC is great, but providing enough vertical material support inside of a titanium base typically results in the stock part creating a lot of bulk right in this area here, right? So most angulated screw channel titanium base options have what we call like a flexible option where you're able to cut it either at 7.5, 5.5, 3.5 millimeters, and they have these horizontal cuts in them. And most implant manufacturers that produce titanium bases have this kind of variable type of titanium base. It's a wonderful option to have in stock at your lab, just so it speeds up and makes things very efficient. It's also very nice because these are machined files, so you have the library files, and you're able to produce something that fits very intimately and very well in here. And then, of course, the ability to angulate that screw access channel allows us a lot of flexibility in the way we produce things. But of course, in that aesthetic zone, especially when we're trying to manage that narrow envelope of restorative envelope there, this becomes a really big challenge. So Elos, of course, they've done a very smart thing where they have actually introduced what they call the guide cut system. So you can see these diagonal guide cut lines here, which allows us to also cut not just in the horizontal aspect, but now in the diagonal aspect to allow us a little bit more material thickness in this region here, especially in the aesthetic zone, right? So it works really well. It reduces bulk in that facial aspect. It really does preserve the restorative material thickness as well, so we have more uniform thickness there. And then as well, now we're able to produce a taller base instead of in the previous example, I would have had to cut that titanium base right at the 3.5 millimeter here, and then you would have unsupported ceramic from 3.5 millimeters all the way up to the incisal edge. Yes, sir. Yes, absolutely. I'm going to show you exactly in the library. Yep, exactly. So we'll go through, I have a little live demonstration as well, so we'll show you how to do it in the order form. So that way, because there's a number of different options that you have to choose from there, and then we'll also show you how you kind of qualify and quantify both the gingival heights and the titanium base height itself. So that way you get a more practical idea of how to work with it within the library. Quick question, who here was working with 3Shape in your lab? Okay, and ExoCAD? Okay, so there are libraries available for both as well. I'm going to be showing you guys 3Shape, but it works very similarly in the ExoCAD libraries. You just have to choose the right option. So a very quick video from Elos here. All right, so the video did a pretty good job already of explaining all the kind of cool features, but I'll go a little bit more in detail. Again, we do have all of these options of doing just horizontal cuts first and foremost. So you can leave it at the 7.5 millimeter if you have plenty of support. Then you can use the titanium base unmodified. If you need a little bit shorter, you can always go 5.5 or 3.5 millimeters. But of course, the big innovation here is that guide cut. So you have these two options here of doing their 7.5 guide cut at this diagonal here, or the 5.5 millimeter guide cut here if you have a slightly shorter material that you need to support there. The other big thing, of course, is this angulated screw channel here. Compared to some of the other manufacturers, they offer a 28-degree angulation rather than most top out at 25. This is very nice because you're able to actually, again, a couple degrees in that anterior region makes all the difference, whether you exit out the incisal edge or if you're exiting out palatally. So that little bit of extra makes a big difference. And the reason that they're able to offer this consistently is actually because they offer two different screw heights. So if you have a titanium base that has a slightly higher gingival height, which they offer multiple gingival heights as well, they have a screw head that still sits right below this angulation here. Whereas most manufacturers have a single screw, which limits it because it'll sit somewhere low here, and then your screwdriver is not able to access that additional, the additional few degrees there, right? So that the screw itself is seated at the same position whether you have a taller one or a shorter one. And of course, the multiple gingival heights is very important as well. The case I'm going to show you today also involves gingival height decision making. So I'll show you how we kind of go through that process. Again, because of that emergence profile, we want our titanium base to be as tall as possible in our gingival height without showing any metal. So we'll kind of show you the decision tree for that. And then the last kind of really cool thing is this titanium base comes, you don't have to sandblast it. So all these retentive grooves are engineered and designed in such a way that actually sandblasting this titanium base makes it detrimental to the retention. So it's a little bit quicker where it already comes pre-treated with these optimized grooves that allow for better cement retention. So no need to sandblast prior to eluting this to your ceramic. So again, a little quick video showing you guys how the guide cut actually works. If you want to do the 5.5 here, you would cut that top portion first. If you're doing the 7.5, then you wouldn't have to cut horizontally at all. So again, you can see here how in a regular titanium base from a competitor, for example, they have this angulation here and how the material looks. And you have very thinning, so often what you have to do is either bring this titanium base or the crown out a little bit to bulk it out, or you're going to cut it down to its 5.5 millimeter cut to have enough material there. Which again leaves a lot of unsupported material right here versus the titanium base from Elos here, Hybrid Base G, which optimizes much better wall thickness as well as offering enough material support here. They also offer a file you can download inside of the library. So when you download the DME file or the ExoCAD library file, they have the guide cut jig. You're able to actually take this, mill it in your own zirconia inside your lab, sinter it, and they have multiple heights. So now you can just place the abutment inside of this, and you can use a diamond disc to just be able to cut this a little bit more predictably. Sometimes I'm in a rush and I'll just grab a diamond disc and zip it freehand, and it works just fine. But if you want a little bit of extra security, they do have this library file you can download in order to produce it. So we've already kind of gone over this, but I think these are really the use indications for it. Obviously, if you need to do any kind of angulation of the screw access channel, that's a wonderful reason to use it. If you don't need to cut anything, again, if you have plenty of material support here without having to modify the titanium base, it works really well and it makes things very convenient. In those types of cases where our placement is kind of compromised, that's where this works best. And again, if the incisal edge, if there's access, the access hole comes anywhere close to that, being able to tilt it backwards is a great benefit. Again, it's already comes pre-coated with a gold finish color, so any ceramic materials will look really good as well. You don't have that kind of graying to it. And then time-sensitive workflow. So what I mean by that is having these already in stock in your lab, just to have something kind of handy. I'm kind of guilty of it, where a case pan sits for a couple weeks and I go, oh, I didn't order the abutment and it's due, so let's just, let's put a titanium base in there and we're going to go ahead and still make deadlines and not make our clients unhappy. So these are the realities of things sometimes. So having something that's very efficient. Sometimes also, if you want to produce a temporary restoration or something like that where they want a very quick turnaround time, this is also a wonderful option to have. So we're going to go hop into the live demo now. So I'm going to show you guys the order form in 3Shape, how we kind of enter all these things in, because the kit does have a number of different options. And then I'm going to show you guys how to use the advanced transformation to get everything in the correct orientation, as well as how we angulate the screw access channel. So I'm going to hop over into 3Shape now, and then we'll start the live design portion of it. Any questions in the meantime while we get things launched? All right. So over here, we're going to obviously go start a new order form. And I'm going to go in here to my sample case. So what I like to do when I get any kind of new scans in the lab, the first thing I do is I will triage the case essentially. So I'll open up my 3D viewer, just look at the scans that we have here and see what's going on. So I don't need the opposing arch here, but I'm going to look at the two scans that I have, the scan body scan as well as the tissue scan or the gingival scan, and see where everything is. So the first thing I note is the position of all the incisal edges relative to the arch form, right? So I'll take a screenshot here just to mark it up for you guys. Here. So you can see here that if we look at the incisal edge of this canine here, for example, the central incisor, our incisal edge of our proposed lateral is going to fall somewhere right there. So obviously the screw access channel from the scan body is telling that we have an angulation issue pretty obviously already, but now you can see as well that we're likely going to have a material support issue based on the geometry of this scan body, right? So immediately I'm looking at this and going, okay, well I need to have, this might be a very good case for our Elos Hybrid Base G. So based off of that, I'm also going to look at the gingival height. It's a little bit hard to estimate here by looking at the scan body by itself. But we'll look at this 2D cross section here. And we can see, okay, from here to here, I have 1.5 millimeters, so I want my gingival height. Let's go with a 1 millimeter just to see. And then if we need to, we can change the order form after. So it does take a little bit of time to enter this in, check it, align everything, and if it's a little bit different, we may have to exit out of the program just to change it out. So now I'm going to go, okay, well, I'm going to have a 1 millimeter gingival height titanium base, and it's going to be the angled hybrid base G. So we're going to go in here into our order form. I'm just going to put a patient name in here, Elos hybrid base G. It is a lateral incisor with a digital impression. We are doing a implant crown. The third option on the right here is the screw retained option. And we're going to go down to our Elos hybrid base G. This case I know for a fact was an Astra EV 3.6. So we'll go ahead and choose the ATE 3.6 option. And then we have all these options here of different gingival heights. So G1, G2, 3, and 4. So I'm going to go with the G1 that we measured out in our 3D preview first. And then lastly, we have the 3 options here. So you have your 7.5, which is your unmodified horizontal, 5.5, again, that horizontal cut here, and then 3.5 if you want to cut it to 3.5. And then our guide cut options are here of the 7.5 and the 5.5. I'm going to go with the 7.5 because I think we have enough material support in there. And then, of course, we have our gingival scan highlighted here as well. So I'll go ahead, hit OK, and we'll just import our scans in. So it's going to ask for the upper scan first, lower scan, and then finally the scan body scan. So typically when you're in 3Shape here, you'll go in and refine the scans, clean up everything, trim it. I've already, in the interest of time, pre-trimmed everything for this case. The system also predefines your occlusal plane. It tries to use AI to do that. I always like to double check that. Very important in these anterior cases specifically because we do like to use our virtual articulator to check our lateral excursions and protrusive movements to make sure that the implant crown is not interfering any of those excursive movements. Implant crowns are typically not very good at handling lateral loads. So you want to try and keep it, slightly out of occlusion and no interferences at all in function. So we don't need to trim the jaws or adjust anything. We just hop right into the scan body alignment phase. Just need to wait for the library to load for 1 moment. Yes. Yes, obviously it's a very ideal case. Okay, so typically when I plan these cases, we use a program called Co-Diagnostics, right? So what we do in there, they actually have an artificial intelligence tooth removal. So what we do is we actually bring in the CBCT of the scan, and then we bring in a surface scan with the teeth that we have. And what you're able to do is actually extract the tooth and extract the alveolar socket there, and it builds an emergence profile around for you. So what we're able to do is then produce them a proposed custom healing abutment at that time, right? So a customized healing abutment at the time of implant placement is going to be the most ideal option. They also have kind of stock anatomic healing abutment options as well, right? So choosing the correct healing abutment in the site there is very important. And again, if you're doing an immediate load protocol where they're taking something out and they're going to put a new crown in, you can at that time sculpt the provisional as well. It's not going to be as ideal, but you'll get something that has kind of the ideal emergence there, right? So sometimes it makes sense to just have them even swap it out once the thing is integrated to be able to do like a custom long-term temporary until you fabricate the final restoration. So Again, it's really dictated by the soft tissues themselves. It's very rare that you'd see papilla like this and gingiva like this, right? They're typically a lot more blunted, but you can still try to make the emergence as natural as possible. So it really comes down to communication and collaboration. So of course, we're going to go ahead and just choose 1 point on here, 1 point on here. It works fairly well. If you need to, you can use a 3-point alignment or a surface scribble on there, and you'll highlight what you want to align. Alignment looks really good here. So it's just going to go ahead and move on to the next step for the insertion direction. At this point, we can actually inspect our titanium base and our gingiva and see how it relates to each other. So the first thing I note is that this looks completely backwards. So the way that it's been imported in. And the reason is that when these are scanned in, the doctors typically are trained to place it so that indexing is facing forward so they can see it. But the library itself is actually oriented in such a way that this is supposed to be on the palatal side. That's not a problem because we have the option to actually rotate the geometry inside of the software. So that'll correct that just fine. The second thing is we're going to check our gingival height at this point. And the reason for that is we want to have, again, as much gingival emergence as possible, like the titanium base, without showing any metal. So I'm going to do a cross-section view here. You can look at it underneath. You can see already that there's a gap between the metal and the tissue. So based off of that, are we able to actually get a taller titanium base here? So I'm going to do this here, draw my cuts, my section here. And you can see from this titanium base to the crest here, we have 1.5, 2 millimeters. So we can definitely add another millimeter and still have a 0.5 millimeter to spare here. Same from the lingual aspect. We have almost 2 millimeters there. So what that means is we had a 1 millimeter base here. We can add 1 more millimeter, so we can do it with a 2 millimeter gingival height abutment. I wouldn't go up to a 3 necessarily, but a 2 I think will emerge much nicer. You can see here, there will likely not be any bone over the crest of the implant here. But sometimes the bone is very, very close in this area here. So if we could bring this titanium base cuff a little bit higher, that's always nicer for the emergence in the tissues there. So I'm actually going to save it at this point. Typically in the past, and I'm going to be speaking with the developers today of 3Shape as well, you would be able to click on the order form here and change it on the fly, but we lost this functionality, I believe, a few years ago, and I'm not exactly sure why, but hopefully they can introduce it back in. But in previous versions, you'd be able to actually choose from here and then choose a different height, and then again go to your guide cut 7.5 and hit OK, and then it would be able to load back in. In this situation, it's going to yell at me and say we don't have the proper kit in here, which is fine. We're going to hit OK and close it. Do I want to save the design? Yes. And then we're just going to go back in, modify our order form so we have the correct height now. Now we're going to go to the G2 for the 2 millimeter gingival height, and again choosing our guide cut 7.5. Hit OK. It's going to ask if we want to auto redesign. I choose no here because it's going to try and finish it even though we haven't done any of the modeling steps, so always press no at this step. And then go ahead and start your design again. We did save all of our trimming of the models and everything, so we just go ahead and yes, we would like to keep our design. So anything that you've done up to the point of saving will already be done. You still need to realign the scan body just because it's considered a new kit. So it's just pre-processing with the AI and applying all of the sculpts that we had made to the model in the preparation step here. So it'll take just a moment to load. So now we can just go ahead and skip right towards the scan body alignment step. Alignment looks very good. So we'll go ahead and proceed to the insertion direction. And at this point, we're going to inspect our titanium base again. Gingival height at this point, you can see here, especially if you look at it in profile view. You can see how this emergence is very ideal. And now if we design our crown in such a way, it's going to emerge very nicely. The lingual's set a little bit lower, but I'm not going to modify that at this point. I think I'm very happy with where we have it here. There's going to be no real metal show through or any kind of graying. You have enough ceramic thickness here as well, but also the emergence here is very nice. So using a titanium base with the gingival height that's as tall as possible is going to be the best option here, always. So now we're going to go ahead and just model our crown really quickly. Flip in here. Sure. Very rough. Place one in here. You can also mirror the contralateral tooth. I'm not a big fan of the shape of this one. It looks slightly deficient. So we'll just put something in here that I think will look a little bit nicer. So roughly somewhere there. I'm going to just pull the gingival aspect here. So this is our pre-design. This is how we kind of visualize where the connection is going to look to appear. So we'll go like this. There. And now we go ahead and select our emergence here to connect to the crown. This is obviously going to be in zirconia or Emax material. So, but we still want to set it in such a way that it's fits nicely and has a nice contour to it. Also, this is the step where you would rotate the actual titanium base itself. The way you do that is you click this little purple icon right here. That's your implant transformation. You're going to grab this new handle that shows up, and you're just going to rotate it. And each implant has a different, so this one has 6 lobes, so you have 6 different positions. Now I've rotated it in such a way that it is in the right orientation with that guide cut facing labially. And we can turn this off. The other thing we're able to do here at this point is also visualize our screw access channel. So if we bring our crown back in that we've pre-designed here and we bring in the screw access channel, you can see where that is going to exit. And obviously that's, that needs to be tilted back. We do have the option, to, again, to go all the way back to 28 degrees. In this situation, I wouldn't go that far back. And the reason being our crown as designed will be quite thin in this area here. So we don't need to exaggerate the angulation as much. I like to go typically no more than 15 degrees. It also makes it easier for the clinician to insert, and you do get more torque the closer you are to 0, right? So sometimes if it's very, very far back, achieving good torque, the screwdriver could have a chance of slipping out as well. So minimizing your angulation as much as possible. You can see here now we have our proposed crown. I would bring this back a little bit further than 15 just because our incisal edge is going to be kind of thin there. If I can bring it back, I'm probably going to go almost 17 degrees, just so we have enough uniform material thickness in that area there. That's a good spot. So we'll go ahead and turn off our advanced transform at this point. Turn off our screw access channel as well. And then we'll do our final design here.
Is angled screws that universal for use any driver? Can use any driver?
So the angle, it's called ball torques essentially. So it's a Straumann shaped like the Straumann one. So it's like a hex, but it's in a ball shape, essentially. So they can rotate it. And all of their screws use that, the angulated one uses that, right? And most systems use the ball Torx as the screwdriver. So typically what I'll do is I'll order a couple, have them in the lab, and then I'll just say, hey doctor, this one is an ASC case. We're gonna provide this in there. Just make sure you use it, torque it to 35, and then sterilize, and please return to the lab. And that's, but again, if you, I'm not sure what the cost is on them. Sometimes it's also a good option to offer it as like a bonus, little extra free thing. If you want to entice them to use it a little bit more. So at this point, we're just going to go ahead and connect our crown to our emergence. And then there's always this little junction line here, so I'll just go sculpt on protected surfaces, just to smooth things out a little bit here. And then the lingual aspect here is a little bit bulky relative to the other two. Also can cut to the opposing, a little bit slightly under occlusion here. And then of course we're going to check with our virtual articulator to make sure that all of our interferences so it is slightly heavy there. So typically I also will look at this, and you'll see I leave a little bit of a gap here. The gingival tissues have a tendency to collapse on themselves a little bit as well. So if we see that the way that I have this crown designed, if I bring it all the way out here, it may look really bulky in this aspect and a little bit long almost. Whereas if I taper it back a little bit, the tissues will actually collapse back in on themselves a little bit here. And you'll have a more streamlined looking crown. And the emergence will be fairly good there. Again, it depends on the patient. Sometimes we do this and that it does look deficient, so you have to really be aware of what the tissue biotype is as well, how resilient it is there, how much tissue thickness we have there. Sometimes pressing on it too much as well is not the best. So just being, in a few tenths here and there makes a big difference in this zone here. But the emergence really is what sets things apart when we're doing these types of cases. All right, and then the last final step, it asks for a final sculpt. Go ahead and hit no. Actually, I should have stopped there for a second. So the reason that the software asked me, I'm going to go back for just a moment, is there's a minimum thickness violation. Even though when you look at the crown everywhere, there are no red areas, the area that is causing that minimum thickness violation is the actual screw access channel itself. So if you see that error and ask you, oh, would you like to apply minimum thickness, I always press no, because we're going to be cutting that screw access channel anyways, right? So ignore this warning as long as you check it and know there's no other red spots anywhere else. So we'll go ahead, press no at this point. We don't need to make any other adjustments or final sculpts or anything like that, but we'll go right to the assembly step. We've already angulated our screw channel. If you forget to do it in the first step, you do have the option to do it here as well, right? So you would go here, you can choose angled screw channel, and then at this point you could tilt it back as well. So you have the option to modify it in 2 spots. The only thing I like to do is I make sure that when we angulate this, that you're trying to stay within the horizontal, the vertical lines of the titanium base as well, because it does allow you 28 degrees of angulation in any direction, right? So just be careful that when you do angulate it, that you're looking at where that screw access channel is relative to the titanium base. You can definitely get away with something like this. A few degrees left or right is not the end of the world, especially if it's more ideal for your material thickness. So just avoid, going anywhere crazy like this. because then, obviously inserting that screw and torquing it down is not going to be an option. So we still want to stay within the geometry of the titanium base itself. Again, we'll go probably about 17 degrees, I think was what we determined before. Something like that. We also have the option to fillet the hole. So this is when we're speaking about that chipping around there. Typically when you have, let me apply this first. When you machine this, what you'll see sometimes is, especially in zirconia, it'll have little tiny micro chips in that area right around the screw access channel, just because of how thin that material is there. So we can always have the option of filleting the hole ever so slightly. So this very sharp edge is very hard for your milling machine to reproduce. So if you do a 0.01 fillet on here, and then we apply that fillet, it's going to add a little bevel to that screw access channel, which gives you a little bit of extra material there as a buffer, so you don't get that little chipping there during the green state milling. 0.1. So you have just this little ledge here that allows like a little bit of compensation, so you mitigate that chipping there. The other option you have here, of course, is for the screws themselves. Sometimes it's advisable, especially if you're angulating it quite far back. So in this example, I'll show you here. If we go all the way back to 28 degrees, that screw has to come in and enter in that access channel. And sometimes you'll notice that it might interfere a little bit here just because of the angulation of getting the screw in. We can also show you via the screw animation here. So sometimes it may interfere a little bit here. So the option to be able to open up the extra radius as well. So if we add, a few tenths here, like even 0.08, it'll just expand that screw access channel just a little bit, so you have a little bit more space here. Again, this is something that you learn with experience. Okay, well, we've done these, and I just trim it a little bit. We'll add just a little bit when we angulate it past a certain point. So it's another extra option that you're able to put in there. In this situation, again, because we're going roughly about 17 degrees here, we wouldn't need to do this. Putting the fillet on is advisable, in my opinion. I do notice, even with fresh, brand new burrs, very often you'll get a little bit of chipping around that area there. So just having that little fillet there really helps to make sure you have a clean looking crown that doesn't have little chips. Not really a functional issue, but it just doesn't look very nice. Or you're going to spend a little bit of time polishing there. Yeah, for sure. I'm not sure. That one I'm not sure, actually.
Yes, I believe there is an option.
Okay, there we go. Awesome. All right, so that's basically how we design these things in 3Shape, and how we select the different libraries and everything like that. So overall, we have a very well contoured crown that fits in our aesthetic envelope, or restorative envelope. You have enough aesthetic material here to block everything out as well. So it's just a really good option to have in your toolbox. So we'll go ahead and close this down, and then we'll just kind of do our key takeaways and take some questions as well if you guys have any. So again, kind of summarizing what we've gone over today, biology really does ultimately set the implant trajectory when we're working in this aesthetic zone or the anterior region. That anterior maxilla really is compromised very often when we're speaking about implant restorations. So that the restorations ultimately inherit that compromise that we have to make with the placement of the implant. So of course we have the advent of angled screw channels and the ability to improve the positioning of our screw access channels, but traditionally we haven't had restorative space in there that would in that narrow restorative envelope. So of course the guide cut design that Elos has introduced here really preserves material thickness there. It helps to protect both our aesthetics and strength of our material by offering enough vertical support as well as tapering things back, so we're able to produce an aesthetic restoration. Ultimately, planning these things early on and trying to mitigate them is always the best recipe. So if you can get involved with the implant planning process, doing a diagnostic wax up where you place the crown in, and then importing a CBCT to see where you can finesse the implant to get it as far palatally as possible. That's always going to be better, but having options is always good as well. So with that, I'd really like to say thank you guys for your time and open the floor to questions if you have any.